Welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/follow. Today in the show, we have Nina Coleman. She is a healthcare administrator, and her Kevin MD article, which we'll talk about today, is titled Melting the Iron Triangle, Prioritizing Health Equity in Dynamic, Innovative Healthcare Landscapes. Nina, welcome to the show.
Thank you so much for having me, Kevin.
We'll get into the article in a little bit. First off, briefly share your story and journey to where you are today.
My healthcare journey started at a very young age. I've always known that I wanted to help people, and I've always known that healthcare was how I was going to do that. I'm very close with my mother, who's a gynecologic oncologist, so I was exposed to the clinical side of healthcare very, very early on. And my mom would always talk about how evil hospital administration is and just talk about it all the time. But I really appreciate a challenge, and I was interested in the prospects of being able to help many people at a given time. And so I decided that health administration is exactly what I was going to do, even though my mom still asks me every year if I want to go to med school still. But from there, I got my Bachelor of Science in Public Health at Texas A&M University. And then I went to Johns Hopkins for my Master of Health Administration. And during graduate school was when I decided that I was not going to wait 10 years to make a difference in healthcare, and I was just going to try to make a difference now. And so while I was in graduate school, I started a student organization at the Bloomberg School of Public Health called Health Administration Leadership Organization, or HALO, which got at like my foundational passion in healthcare, which is clinical and administrative collaboration and shared leadership. And then in my second year of graduate school, I matched with Elation Health as their first administrative resident. And I really, really liked it. I don't think there had been any other health technology residencies at the program that I was in, but I was really, really surprised how supportive and empowering all of the folks are at Elation to really empower me to pursue my passions now, regardless of how early I am in my career. And so now that I've graduated, I am still at Elation working as their manager of primary care advancement.
Now, a lot of us on the clinical side of healthcare, they have perspectives not dissimilar to what your mom says about healthcare administrators. So tell me, from the administrator perspective, how do you positively impact patients' health?
So I like to think of it as we're helping people help people, which is a little more far removed from the actual trenches of clinical medicine. But I think that every role in healthcare is necessary. Even at Elation, I really try to work internally to let even the engineers know that you are saving lives. Seems far removed, but you are. And I really am passionate about uniting everybody in healthcare under the fact that the large majority just want to help people. And that's what I love about Kevin MD and the community that you've built too, because I love how you say people that are rarely ever heard from in healthcare. And yeah, like I said, I really do think that if there was a little bit more collaboration, then the healthcare system wouldn't be as broken.
So what are some ideas that you have to bridge that gap between the clinical side and the administrative side? Because no matter which institution that you go to, you're always going to find a little bit of a chasm there. So what are some ways that we can bridge that chasm?
Yeah, so what I tried to do for my student organization was a lot of seminars and education. I noticed that during graduate school, there was a lot of financial management, there was accounting, which I didn't really like, and there was like public health and classes like that. But I was looking for a medical terminology class because I think that really understanding the clinical perspective is as much as you can is really important. And from the other side, like if clinicians understood more of the perspectives on the administrative side, that would be a little easier. But I think practically in the workplace, I think shadowing and mentoring people that are on different sides of healthcare as you would really open people's minds to having different perspectives and recognizing that we all are trying to do the same thing.
All right, so let's move on to your Kevin MD article that was recently published. It's titled Melting the Iron Triangle, prioritizing health equity in dynamic, innovative healthcare landscapes. Now, for those who didn't get a chance to read your article, just walk my audience through it and share the story of why you decided to write it.
Yeah, so I actually started writing this article in October or November of 2021 during graduate school. So my program had a capstone project, and there were three options. And one of them was this Stoll essay competition, which is this 15-page essay about a relevant healthcare topic that you submit to the ACHE, and the winner gets published with the ACHE.
Mm-hmm.
Selected to represent Johns Hopkins in this national competition. And although I wasn't selected as the winner, I still really knew that this is such an important topic that maybe doesn't is not as well researched as others. And I really thought it was important that people hear it. And like I said, Elation has been so supportive and so mission driven and so empowering of all of my different passions and of being a leader in healthcare, everyone. And so I heard back from you that you were going to publish my paper. I was really, really excited to have the opportunity to share, because I was fascinated by the relationship between innovation and equity.
Mm-hmm.
I really started to think about, are the robust, awesome, innovative, accessible new innovations coming out of the pandemic, are those really helping the people that actually needed them the most? And so I started diving into historical context of different pandemics and public health crises and all of the innovation that came from that, like even washing your hands historically, germ theory, all of that. And I started to realize that accessibility is not, the people that need it the most are not getting it. And so that's when I started thinking more about the iron triangle, because that is something I learned in undergraduate school with cost, quality, and access. And the theory asserts that if you try to improve two of those things, the other one will worsen.
Mm-hmm.
And so, like I said, I appreciate a challenge. And so I was trying to consider how you could improve all of those things. How could you create an initiative or a new innovation that meets all of those criteria? And I really tried to think about it. It is very difficult, but I think the whole thing with equity is that, especially health equity, especially digital health equity, is that it's not going to improve unless there's a true intentional effort to improve it.
So, as it relates to the current pandemic, so give us an example of a technology that you're specifically talking about that intersects with that issue of health equity. Which technology in particular would be a good example of that?
So, for instance, telehealth.
Mm-hmm.
Telehealth is great, and it improved access for so many people, particularly rural populations, and especially in the new digital era. Accessibility and ease of use and convenience are all very important things. However, not everyone has a laptop. Most people have a phone, but not everybody has a phone. A lot of people don't have internet. And so what about those populations of people that can't go in to a clinic or practice during the pandemic and also don't have access remotely? And so in that case, I did a bunch of research thinking about, okay, so 80% of people have a mobile phone. And so that's why I start my recommendations for how to address digital health equity by leveraging the mHealth opportunity. Everything should be accessible on a phone without internet, different bandwidth styles, different screen styles. And then patient-facing tools, interestingly enough, are generally less equitable than other different equity tools and innovative tools, because it starts going into all of the social determinants of health. And then I learned about digital determinants of health, which include perceptions about technology to help or harm, societal and cultural norms. And so patient-facing tools is a really, really huge opportunity to be able to empower patients to take charge of their own health and have that patient autonomy over their own lives and be able to have information and access to everything that they need.
And when you say patient-facing tools, what exactly do you mean by that?
So that would be something that you as a patient interact with the healthcare system with, as opposed to on the back end, tools for clinicians to say, gather data about patients, to be able to see patient data visually. So the patient-facing tools is definitely the future of healthcare, I would say, especially as apps and remote patient monitoring devices, all these things hopefully one day will be connected so that in this new age of digital information, everybody has access. But to give everybody access, we really, really have to make an effort to make sure that the people who traditionally are undervalued and underserved and vulnerable have access first.
So one example certainly would be those patient-facing portals that a lot of electronic medical records have. So what's the current situation now, and how far do we have to improve before we get to your ideal?
See, I'm an optimist. And so one of my weaknesses is that I tend to just believe that anything is possible and I need to be grounded in reality some more because I haven't been maybe beaten down enough by the healthcare system yet. But I think that patient portals for EHRs are an excellent untapped resource for this because they're already built and they already have a lot of the capabilities to be able to be a resource for patients in their lives, not even just at the point of care, but beyond. And so I think minor adaptations to the patient portal, for instance, just filling in more resources, connecting to community centers, external resources, explaining diagnoses, alerts, having access to clinical opinion, all of these things, and as well as accessibility concerns such as maybe audio, having like an audio recording instead of just reading, having different font sizes. All of these things will help transform patient portals into a tool that people could use. And uptake of these things is a completely different story. But I think we just have to start by at least offering these things. And then from there, we can go into how to spread the word about the potential.
So one of the things that you mentioned earlier was sometimes there's some cultural hesitancy when incorporating technology in one's healthcare. So talk more about some of those cultural issues that come into play when it comes to digital health equity.
Yeah, absolutely. I come from a position of privilege, and I do touch in that in my article, I think, realizing that I did all of graduate school fully remote, and I'm so lucky to be able to have all of the tools necessary to complete my education, and not only just my education remote and fully online, but also take care of my health and meet with my primary care provider all online. And so the cultural norms, I think a lot of that comes from just being traditionally marginalized communities have less trust in the healthcare system for good reasons. And so it's not their job to just trust that we as a healthcare system are doing things to make everybody's lives easier and to give everybody a better quality of life. It's our job to go out of our ways to prioritize getting vulnerable populations and communities access and to the resources that they need to feel comfortable to be able to do that.
We're talking to Nina Cloven. She's a healthcare administrator, and we're talking about her latest Kevin MD article titled Melting the Iron Triangle, Prioritizing Health Equity and Dynamic Innovative Healthcare Landscapes. Nina, what do you see as the path forward? So what are some immediate things that healthcare systems can think about or do to really improve those digital health equity issues?
The first thing would have to be primary care. Primary care is the source of everything in terms of all the social determinants of health that impact a person's health. Healthcare itself only makes up for 10 to 20% of a person's health. And so I think it has to be any digital or any health equity measure or initiative in general has to begin and start at primary care. And I've learned more. That's become more of a recent passion of mine at Elation, is just learning more about how undervalued primary care is in the healthcare system. And if I could share a personal story, I think a little bit over a year ago, my primary care physician, my mom's primary care physician, our families saved my mom's life, or could have saved my mom's life. Me and my mom both have migraines, and her migraine medicine stopped working. And so her primary care physician said, okay, and referred her to a neurologist who found an unruptured brain aneurysm. And my mom herself is a gynecologic oncologist. And so it's very strange to experience healthcare as a patient. And so brain aneurysms are rarely ever found unruptured. And when they are found and rupture, it's a 50% chance of mortality. And so my mom was lucky enough to go into, to know which physician to go to, which doctor, go into the hospital and get what is called an endovascular coiling procedure.
Mm-hmm.
And so I spent all day and all night in that hospital, and it really made me think about healthcare and as a patient, and how nobody wants to be in a hospital except for the people that are working there. And I think primary care is uniquely positioned that every primary care physician experiences primary care as a patient. And my mom's situation is unique because she actually didn't like it. They say doctors make the worst patients, and it's true. She just knows too much. But how fortunate are we that she had the medical literacy, we had the financial resources, we had access to all information to be able to get that treated. A lot of people don't have that. And that's why I believe that primary care has the ability to kind of address all the social determinants of health and be able to really empathize with patients because they are in those situations. And so primary care, more than arguably any other specialty, can really understand the patient perspective and be able to give them all of the resources and build a relationship with them to be able to have a better quality of life and kind of, I guess, go through the healthcare system together.
Well, as a primary care physician myself, thank you so much for saying those words. And I completely agree with everything that you said. And my final question, your take-home messages to the Kevin MD audience.
I think my take-home message would be, I guess for your clinical audience, I would say, invest in your relationships with administrative healthcare workers, because no issue in healthcare, not digital health equity, not health equity, none of that, those systemic issues will get solved without collaboration. We have so far to go, so far to go. And so I think a strong foundation of collaboration and teamwork is the only way that we'll be able to fix this broken healthcare system.
Nina, thank you so much for sharing your story time and insight. Thanks again for being on the show.
Thanks.